myths about hip pain are going to get debunked. I think these are probably going to surprise you. Let's listen. I asked you guys, give me your top 10 myths, and I've got 10 here that I'm going to debunk. I'm going to leave some of the juicy ones that will probably surprise you scattered around the middle and the end. So let's go. The first one. So steroid injections are only effective treatment for lateral hip pain. Is this true? Is this false? Complete myth. People who have lateral hip pain, that possibly is as a result of gluteal tendinopathy, we know, respond really well to exercise. That doesn't mean you've got to get the needle and start shoving the needle in there or give them a shot. That's not the only option. For some, it might be suitable, but to say that it's the only treatment for someone who has lateral hip pain as a result of that is flawed. That might cause some controversy, I don't know, but nonetheless, something that we need to consider. The next one, probably going to be a little bit more intriguing. So the next one is this. Does clicking of the hip mean a degenerative hip? This one I'm going to dive into a little bit more detail. So hips click, right? If anyone who is listening to this doesn't have hip pain, my question to you is this. Do your hips click? Do your knees click? Your elbows, your shoulders? It is normal. A clicking joint doesn't equal a painful joint necessarily, and certainly a painful joint that clicks doesn't necessarily mean a degenerative one or a crumbling one. Often there are just things moving around. It's normal, tendons flicking, whatever it might be. It is quite common, more often than not benign. So I wouldn't worry about it. I tell you what though, it definitely doesn't correlate or mean that it's a degenerative hip. So you definitely have to kind of consider that. This will probably bring me into my one of my favorites, which is the third one, and that's this, right? So does more pain equal more damage? The answer to that is categorically, absolutely not. So what we understand, especially about hips in particular, is that the severity of your symptoms isn't going to necessarily distinctly correlate with something that's going on. I'll give you an example, right? You can have someone who's got they've got two hips. I was going to say got two hips. They hopefully have two hips, but has one painful hip and has an X-ray or an MRI scan on both, and it finds incidental findings on the other side that make it look like it should be more painful, but it isn't. And we've seen that all over the body, whether it's a disc in the back that's asymptomatic, a labral tear, arthritic changes, whatever it is. What we understand now is that a pathological change in a joint and a soft tissue, whatever it might be, but in particular with the hip joint, it won't necessarily correlate with a higher level of pain. Also, you can have people that have tons of pain. Actually, there's not much stuff that's going on. A lot of that stuff comes down to the fact that pain is very complicated. This is the thing that controls it all. So, does more pain equal more damage? No, that is untrue. Some of these are great. I'm excited for this one. In fact, I might leave that one till near the end because that one's going to get me going. Right, it's not going to get me going, but you know what I mean. It'll get me excited. But not that that sounds any better, me saying it like that. So, next one. Can you or can you not run with FAI syndrome or arthritis of the hip, and is it bad for it? That's not true. So anyone who has FAI syndrome, anyone who has an arthritic hip, absolutely safely is able to run. There's no reason why you're not able to do that. Now, don't get me wrong, some might not be able to do that. Some might find that it provokes their pain. Some might find that it's too irritable. Some might just be like me. I don't like running. But it might be the fact that actually, like, maybe you want to do that stuff and it's safe. It's not going to make your hip wear any quicker. It's not going to make the FAI get any worse. But if you're doing that and your symptoms are getting worse, the question is there something else that you could probably do that makes more sense because it's not as painful? Yes. But for those who have an arthritic hip that think, actually, if I run more, it's going to wear it down more, it just doesn't work like that. But like, from my perspective, I think life is short. If you love doing that and you want to do it, fill your boots. But I tell you what, it's not going to make your hip joint health deteriorate anymore. Let me bring it into this next point now, because this is interesting. It follows on from the point I just said. Can physio, no, let me rephrase that. Maybe do it this way. Physio cannot help me because my hip pain is structural. Now, with FAI syndrome, a lot of that could be structural components that drives it. So the question is, how is physio going to help? Well, look, physio isn't just about giving exercises specifically for one muscle group. It's around building tolerance of the joint, tolerance of soft tissue structures like muscles, making it more robust, making it more stronger, making it more resilient to function and activity and sport, whilst also having a positive impact mentally, so making someone a bit more psychologically resilient and tolerant to activity and exercise. So physio, albeit, yeah, there's a lot of exercise involved and things to make you physically better, but actually psychologically it will help your resilience as well. And just because you've got a structural component that drives it, the question is, how long has that been there for? Because I tell you what, it may well have been there longer than since you've had your pain. So to then immediately start blaming the structure specifically, and that's bringing me on to my next point, which is making me like happy looking at it. You cannot just blame the structure all the time. You cannot blame it and then think that actually the only way to treat it is with surgery. That brings me on to this next point. Probably my biggest peeve, my biggest pet hate, my biggest myth that I always like to kind of address, and that's this. An anterior pelvic tilt is bad. An anterior pelvic tilt is not bad. People have pelvic tilts. Look, we're not robots. Pelvic tilts are no different to any other part of your anatomy where it varies, whether it's a difference in position of the pelvis, shift, tilt, rotation, we're all different. And pelvic tilt, in particular, an anterior pelvic tilt will be greater and less relative to particular ethnicities, gender, even throughout age, it will change. So blaming someone or pathologizing someone's normal anatomy for their pain, for me, is an absolute huge flaw that I really detest. And I tell you what, people don't have anterior tilts or whatever because muscles are tight or muscles are weak. They are born with a pelvis that is in a position because we are not cars. We were not built in a factory. We're all different. And that really always gets on my nerves. The other one is this. Piriformis is always causing my buttock pain. Guys, I don't know if you had a little dive into the gluteal region, but I tell you what, there is more than one thing around that area. There are so many muscles, there are so many vascular structures, there are nerve structures as well. It is very difficult to determine a singular cause of someone's buttock pain. Now, that's not to say that you can't, you can, but to blame the piriformis in isolation is flawed. Because even as a clinician who specialises in hips, I tell you what, it is fairly challenging to be able to distinctly isolate one muscular component to someone's deep gluteal pain. That's why we refer to it as deep gluteal pain syndrome, because there are so many components to it. So once you've been able to whittle down and you think it is muscular, there are still other things that could be playing a role there. So you have to consider that. But we're going to have other videos in the future that will dive into that in a little bit more depth, diving into the buttock. Maybe that's a good video name. I might call it that. Hip mobility is essential. It isn't. Hip mobility isn't essential. People are just started to assess about hip mobility more now than ever. The thing for me about hip mobility is this. More often than not, the people pushing hip mobility are not even aware of things like femoral torsion, acetabular versions, and different hip profiles. Basically, the way that different anatomy of the hip will allow different ranges of movement and movement patterns for those hips. So for example, some might have less internal rotation, some might have more. Some might have less external, some might have more. That might not just be because the hips are stiff, that might just be their normal anatomical makeup. And sometimes pushing towards hip mobility as a one size fits all can actually be a problem, make things worse, and actually probably not help. So that brings me on really to my last 2 points, which to be honest, I don't know which one to finish on because they're both equally important, maybe a little bit controversial. Let's do this one first. If I have a hip replacement, my exercise is going to be limited. It isn't. Hip replacements will absolutely open opportunities, allow you to thrive, allow you to have a great ability to do more exercise and activity and be physical, have a better quality of life. That hip replacements are not there to give you more disability. And the prior video that I've done in regards to am I too young to have a hip replacement really focus on this stuff, because no, you're not. A hip replacement is there to improve someone's quality of life and allow you to do more exercise, allow you to be more physical and have a better quality of life, not to limit what you can do and make you feel like actually you have to be a bit more reserved. But don't get me wrong, there are scenarios where probably if you're doing sport that you might want to, or possibly might have some limitations, but for the general population, that certainly isn't the case. Now, this last one, I don't know, it's a bit ropey me saying this, but I'm probably going to get some pelters for this, but bear with me anyway. Let me try and at least back it up first. Working on fascia and stretching is enough for hip pain. It isn't. Working on fascia, my perception of fascia is that it doesn't really move. And I say perception as in that's just anatomy. Fascia doesn't move. Releasing fascia, releasing muscles, I wonder what that even means, because you can't release anything really. That's not to say that you can't have pain relief from hands-on therapy, but to package it as it's releasing something is flawed. I think stretching has an absolute place, but for someone who has hip pain, to say that that is enough, or to say that releasing fascia is enough, I think is flawed. It's flawed because it doesn't take into account really the understanding of pathological causes of hip pain, which is seldom because things are tight. And a good example of that, loads of people who have hip joint pathology will often report things like hip flexor tightness as an example, and will often be given things like stretches or mobility to improve that, when actually that's not what's going on. Although it feels like that is tight, there's other things that are driving it. And to be honest, that's the thing that I need to consider.